Welcome to A Shot in the Arm podcast. I'm your host, Ben Plumley, and this is a podcast about innovation and equity in global health. Because if there is no equity, what is the point of innovation? Well, before we get into today's show, just your friendly start of show reminder to subscribe and like us wherever you download your audio podcasts. And of course, visit our YouTube channel at www.youtube.com/@shotarmpodcast. Subscribe there, like, and smash that notification button so that you can be updated when fantastic new episodes like this one go live. Well, I'm really excited that today we are joined again by friend of the pod, and soon to be, I hope, someone we see a lot more of. It's Mike Reid, who is the Associate Director of Global Health Delivery and Economics from the University of California at San Francisco's Global Health Sciences. Mike, welcome back to the podcast.
Great to be with you. Thank you for having me, Ben.
Now, what do we do with UCSF to get them to give titles that are short, succinct, and easily memorable? I am so sorry that I had to read this.
Yeah, apologies for that. I blame it on Eric Gooseby. Oh. He came up with that name, I think.
Well, so much to blame Eric for. But look, we thought we would have a sort of 38,000 state of global health. Where are we? What are we doing? What have we got wrong? And I thought it was really important to have the conversation with you about this, because as well as this fantastic title at UCSF, you are also within for the author of a Substack, Reimagining Global Health. And within for has produced a series of posts that I find absolutely gripping, and I strongly recommend everyone to subscribe to your Substack. I jokingly call them the 7 deadly sins, but they are in fact the
7 dead ideas in global health.
And I thought that would be a great place to start. Now, certainly global health is going through such a rapid and profound transformation, but why list these dead ideas?
Partly, I wanted to list them to articulate where I think we've made mistakes over the last few years. But I think we also need to name the failures so that we can move forward into whatever lies ahead. So these were just a few of the issues that bubbled to the surface for me in global health that I think we need to address.
Yep. Well, do you want to kick in with some of them? I mean, again, I found them absolutely, really profoundly very important and have helped me rethink how I'm approaching it. But how would you articulate them?
Sure. Well, I will say just one other caveat. These are ideas that have developed or percolated in the context of conversations with Eric Gooseby, who we mentioned earlier, a friend of the pod, I believe, and for me, a really important collaborator and mentor. We've talked a lot about what the future looks like over the last few months, and one of the ideas that was clear is the notion that we know what works is no longer the case. So dead idea number one is that we know what works. I think historically in global health, we have spent a lot of time scaling interventions, solutions, new tools that come from high-income countries, come from donors, and aren't responsive to the needs of the constituencies that they're there to support, or they're not informed by a rigorous implementation science agenda. And so that first dead idea is really about bringing some epistemic humility to how we introduce new tools, how donors invest in programs, recognizing that they have to be informed by local realities. And as an academic, my perspective is they also need to be informed by rigorous implementation science. What happens in a clinical trial doesn't necessarily end up being what gets replicated on the ground. And so I think that notion is where that first idea came from.
Because there's a tension there between, if there is an innovation, whether it's a biomedical one or a behavioral science intervention, and it's new, you want to prove that it works. On the other hand, you've got implementers of programs who are running national programs, running local programs, they live and breathe what works. And why in heaven's name should they have to go through another rigorous set of monitoring and evaluation to show that this particular innovation works? How do we sort of meet each other halfway?
Yeah. I think that is a really important tension to speak to, and I'll just add to that, Ben, that there is also a prevailing discourse right now that we have gold standard science, and we don't need to be doing any more implementation science. And I will say that I am not in favor of perpetual pilot studies. But I do think oftentimes there is an important contribution to be made by contextualizing new innovation within the paradigm of implementation science. I think the other piece to this dilemma, though, is being responsive to the needs of local communities. And often donors bring their own agenda. And that notion of we know what works, the sort of the IKEA flat pack approach to global health, as I write in the blog, is a dead one when it fails to be responsive to what communities need or what they want or what they're going to scale and what governments can afford in the long term.
Yeah, and there is also this, related to that, this question of if you are a program implementer, almost by definition, you are always looking at how you can improve your services. You're always looking to see how you can reach more people more effectively, build greater collaborations with the communities that you're working with. So the idea that someone from above comes down and says, here is the innovation and here is the way which you need to monitor and evaluate to show to us that you are capable, worthy of delivering this intervention, I completely agree. That is absolutely dead. So dead idea number two.
Dead idea number two is that health is a technical problem. And this is really informed by a sort of a misguided approach to global health that really just sees donor investment in health and global health interventions more generally as technical issues that we need to address, problems that need to be solved. And what that post is really focused on is actually that in almost every setting in low and middle income countries, health is also a political issue. And if we fail to politicize health, if we fail to get governments to respond to the needs of their communities, if we just see it as a problem that we can solve with donor resources or new tools, then ultimately we're not going to lead to sustainable change. And I think one of the challenges in global health right now and over the last decade is that there has been a complacency that has been associated with how funds have been mobilized, insofar as those funds have not been mobilized concomitant with a commitment from partner governments to invest in those programs. And I think we're at a point now where we need to repoliticize health. We need to use donor resources where appropriate to motivate for partner governments to invest in health. And clearly, as donor resources contract, as the donor landscape changes, the importance of domestic resource mobilization becomes more and more imperative. And that is where politicization from community activists, but also from healthcare workers, from recipients of care is crucial. And so that's where the idea that health is a technical idea is a dead one.
And there isn't a single country in the world where health is not a political issue. Right. One could even extend that to North Korea, but certainly, the countries that you and I have our nationalities associated with, the United States and the United Kingdom, health is absolutely a political issue. And it is extraordinary, isn't it, that we would think that a technocratic global health model could be imposed upon countries without the ramifications of that being thought through.
Well, maybe I'll just add to that, and this is the wisdom of a colleague from PEPFAR, Mike Ruffner, who would often say that for ministers of finance, health is often at the bottom of their list of priorities. There are so many other things that are more important to a minister of finance in terms of where they allocate resources. They want to ensure that, you know, businesses are enabled to be as productive as possible, that trade and agriculture, you know, move forward. And in that context, health is often not a priority. And so that's where I think there is important work that should be done to motivate for health to be higher up the priority list.
Yeah. I mean, that's an argument that, you know, I know UNAIDS, certainly from as long ago as Peter Piot's tenure of being executive director, that, you know, love health ministers, but our targets are the ministers of finance. Yesterday, I say yesterday, during the course of these set of podcasts, we helped launch a report that was written by the HIV Leadership Forum, a group of directors generals of national AIDS programs from around the world. And I had the chance to talk to Dr. Thembelihle Zulu from South Africa, the head of the National AIDS Council there, who's saying, well, look, you know, 70% of our budget is domestic already. So it's what happens with that balance that is so key. So I agree. I fully agree with that. And I think this was one of the Substack posts that I expressed my enthusiastic support for. But anyway, the next one.
So the next dead idea is that donors know best. And it doesn't really need too much unpacking. I think it's fair to say that, you know, throughout the arc of history, donors have always done what is in the interests of the country that they represent, and oftentimes that is a self. And that is an enlightened self-interest. You can both care about the lives and welfare of people in poor countries, but also introduce programs that benefit the donor country. But I think moving forward, we need to understand that donors are just one part of the equation. We should not and shouldn't be expected to set the agenda. However, historically, there has been a sort of a command and control approach to donor investments, a sense that countries will be compliant with the expectations of those resources. And I think there is an opportunity to rethink that.
Yeah, and I think it's absolutely happening. Again, this HIV Leadership Forum is assertively pushing their leadership and marking their ownership of that territory. And something we'll be coming back to, I'm quite sure, very frequently in future podcasts. What's next on the menu?
So the next dead idea is that more money means more impact. And this is a reflection, a personal reflection based off of working inside a government donor enterprise and having some insight into the inefficiencies of those programs, and the reality that oftentimes donor investments serve a development industrial complex that doesn't necessarily advance impact in the country that the funds are meant to go to. And in fairness, I think the new US administration has made some decisions around donor financing that are responsive to a perception that there is inefficiency, that things can be done with less money. And I think some of that could be the case.
That is quite a statement that is going to be interesting for me to follow up on, isn't it? I mean, in a sense, there is absolutely a problem, and that needs to be thought through, but you think through it. I can say this, I know you can't. You think it through carefully and with intention, not with a sledgehammer. But I mean, if you look at the way in which money has been spent, so I'm sort of fully endorsing what you said. You look at the investments, particularly of international NGOs delivering services on behalf of donors, including things like Global Fund, country coordinating mechanisms, requesting this. They have a level of of cost associated with them that are significantly higher than national programs and abilities. And that, I think, is a thing that we all have to really be cognizant of. There are undoubtedly ways of doing things with less money, with greater impact, and that's
absolutely. And there's a rich academic literature around this that we could unpack at length. But I think this is a moment to reimagine how donor financing is done in such a way that we see results from that investment that enables crowding in of additional resources and is done more efficiently.
So next on the list?
So the next on the list is that vertical programs are efficient. And I think it's fair to say that if you look at the global HIV response, there is truth to that statement, even though I've claimed it as a dead idea. I don't think we would have achieved the scale of the impact in the HIV response over the last 20 years if some of that investment had been dispersed into integrated horizontal programs. And we were able to respond to the threat of HIV 20 years ago by investing in vertical siloed programs. But I think it's a dead idea because I think we've moved to a point now where the future of the global HIV response and global health more generally demands an integrated, coordinated approach that leverages domestic resources and donor resources. And I think that is best served by investments that are integrated into, as it relates to health, into primary care infrastructure, broader health system priorities.
And that is going to be driven by the countries. It's going to be their national health strategies. I completely agree. Now, I used to be an AIDS exceptionalist, and I think HIV's done a lot of good, but it has done us a disservice, I think, over the medium term in dealing with the exceptional, the vertical versus the integration approach. I mean, ultimately, again, if resources are tight, and you have populations of folks who've been on antiretrovirals for a good number of years, they're now beginning to experience health challenges, non-communicable diseases. This is something our good friend Eric Gooseby, again, is very concerned about. I mean, it makes no sense to continue to provide a dedicated, separate care pathway when there are, hopefully, services available for high blood pressure, for kidney disease, you name it. And this is going to be something that will be a fun feature of future episodes because, you know, I'm now known for saying integrate or die. And our good friend and co-host Yvette Raphael had some very pertinent words to say at the start of the Kigali AIDS conference about integration. And if you're under 18, you should just close your ears at this point because she says integration is bullshit. So there is going to be a conversation, I think, that's going to continue there.
Yeah, and I think that's a fair point. I think it depends on what you're integrating into. And I know that there is a lot of anxiety out there that if donor resources are integrated into very, very fragile healthcare systems, then those investments may not be impactful. And that's definitely been true over the last 20 years as you look at how HIV investments have had their impact. I will say, though, that there is an opportunity to rethink the mistakes of the last 20 years. And one of them, I think, was that, to use the old African adage, if you want to go fast, go alone. If you want to go far, go together. And maybe we wouldn't be in the position we are now if at the beginning of the global HIV response, there was a more deliberate approach to investing in health systems that built the national health systems, that was more deliberate around shared ownership and partnership, things that Eric Gooseby was a champion of 15 years ago when he was the global AIDS coordinator. And instead, what we did was we invested in very vertical siloed programs with tremendous impact from an HIV point of view. But as we've seen recently with pause in donor funding from the US government, a lot of vulnerability when that funding goes away.
And the rubber hits the road with what we nicely term key populations, men who have sex with men, drug users, sex workers, for whom the National Health Service providers are probably not places that they go to get health, to put it very mildly. They may very well feel stigmatized and discriminated against, if not persecuted, if they were try to be incorporated into those. And so there was a logic to making sure that there were services that were available for folks wherever they were at, but that got them the services that they needed, with a view to controlling HIV at a population level. It's going to be a conundrum going forward. Now, if my maths is right, we've got 2 left, right?
That's right, yeah.
Wow, extraordinary.
And number 6, the sixth dead idea is that measurement equals progress. And so this idea is sort of informed by an assessment that over the last 10 years, a lot of HIV investments have been predicated on showing that programs reach targets, whether those are targets for scaling prevention or putting people on treatment. And many of those are process or programmatic targets rather than hard outcomes. And I think I have 2 reflections. One is that that approach can lead to distortions of data that are informed by a desire from the recipient of funding to procure more funding. So they want to show success, which is often an expectation or a requirement of future funding. And also a reflection that the things that we should be measuring, the things that really denote impact, are harder to measure.
Yes.
And so in the HIV response, the things that maybe we should be reflecting on right now are how close are we to truly reducing incidence, 0 new cases of HIV acquisition, or 0 mother-to-child transmissions. I think the other kinds of indicators in the HIV-TB space would be related to deaths from TB. We're in a moment right now where we should be able to document how many people are still dying from this disease, which is curable, preventable, treatable. And unfortunately, we haven't measured it for the last 20 years. We've measured number of people on treatment, we've measured scale up of TB preventive therapy, but we haven't measured the number of deaths from TB, which is an unfortunate scenario, because if we'd have invested in targeting that as a goal, we might have achieved it.
Yeah. And that's an example of something quite concrete, quite tangible, that you can measure should you put your mind and your money behind it. Our challenge, of course, with HIV prevention is that we're trying to measure how many people didn't get infected, which is in its very nature much, much harder. And of course, it's not a moment in time, because people may be engaging in high-risk behavior and they may not, on that one occasion, seroconvert, get infected, but that might happen further down the line. So it is hugely complex. And I think the global health movement is, HIV is on the sort of the front line of this, as we try and prove to funders north and south, east and west, that investment in HIV is crucial. But we've got to be able to think through how we demonstrate impact in prevention.
Yeah, I agree. I mean, and not just prevention, but programs writ large. I think we need to be smarter about what we measure. We are on the cusp, I think, of being able to eliminate HIV in some countries. Australia, Eswatini, Rwanda. It's conceivable that if you were able to scale lenacapavir to enough people in those countries, given the small burden of HIV disease, you could eliminate HIV as a public health problem there. Eliminate, which is a fairly austere measure. Why I mention that is because if we don't set ourselves targets for those, if we don't measure those things, then we won't ever be able to show that we've achieved them. Yeah.
And that is a very positive, call to action, in that here you are talking about elimination of HIV. And that is essentially a prevention target. Okay, what's last on the list?
So the last on the list is we're on track towards achieving SDG Goal 3, which is the health goal.
Oh my word.
There's a lot that I could say about that statement. I think for me, the reason to raise this as a dead idea is really we need to be honest about the trajectory that we're on, whether that's deaths from maternal mortality deaths or TB, new infections from HIV. And instead, oftentimes, I think there is a discourse that suggests we are on track towards these things, rather than a more sober reflection of the failures that are stopping us from getting to achieving those. And I think that, that whilst there is political value in having these high-level targets, there's value in those kinds of ways of thinking. I think we need to move beyond them as it relates to important health outcomes.
And this, of course, is ending AIDS as a public health crisis by 2030, which, of course, is something that the UN has had to operate to because it's something its member states agreed to. And, as well as recognizing the problems and challenges, for me, it's also accepting the fact that political declarations and targets may not always be rooted in reality. And so for me, it's about what is the long-term agenda, the next 15, 30 years, and how do we make sure that the people who are living with HIV now have access to the very best services and can live as full, healthy lives as possible, and that we really, really focus in on prevention. And to your earlier point, make really concrete, really achievable strategies to bring those new infections right down. I think these, your 7 dead ideas, your 7 deadly sins, because they may be dead ideas, but they still percolate amongst the thinking of many global health practitioners. I think they're a really, really useful guide for us. There were just 2 other things I wanted to get your thoughts on as we noodle on the future of global health. And that is actually the role of faith communities, because we talk about we need multidisciplinary responses, we need partnerships, and we've spoken about communities, and I think affected communities have actually been very successful in not only demanding seats at the table, but bringing their folding chairs and taking those seats at decision-making tables. Where we've not been so good, I think, is in mobilizing a core component of people's lives, particularly a Pan-African experience, and that is the role of faith communities, both as sources of community, but also as providers of healthcare, and also as, quite understandably, resources to help people understand the world that they live in. And I know this is something you're very committed to as well. What do you think we have to do to sort of re-engage with the communities?
It's a really great question, and something I have been thinking about. So thanks for raising it, Ben. Maybe I can answer it slightly differently, though. You've highlighted the importance of faith-based communities in LMICs as part of the global health response, and I think that's absolutely right. They offer an extended capability to ministries of health, and certainly in many countries, the HIV response has relied on the church association hospitals. But I wanted to flag the fact that part of the reason we're at this inflection point in global health is because of the change in political leanings and administrations in the US. And we're at a point now where we should be engaging faith-based communities who are key supporters of the Trump administration to underscore the value, the moral imperative of global health programming. Unfortunately, I think the global health enterprise over the last few years has failed to persuade or make the case to faith-based communities in the US of the importance of global health, both to their worldview and to the faith that they adhere to, but also to the policies that the administration fund. And part of why we are where we're right now is because I think that constituency hasn't advocated for global health in the way that they could have done if we'd have been more thoughtful about engaging them.
I mean, Saddleback Church over in California, that was always traditionally our evangelical supporter, has sort of faded in prioritization, and of course many of the American evangelical faith-based leaders have been very active in different countries across Africa and have a completely different worldview. So it's been hard to find ways of coming together. The one final question I wanted to ask you was about artificial intelligence. And I think we live in a world where clearly intelligence of any kind is a good thing, more so now than ever. But how do you see AI particularly helping the global health agenda?
It's a great question. I'm curious how long we have to talk, because I think I could talk about this for many hours. I have the privilege of co-chairing the Lancet Global Health Commission on HIV and AI, and we are wrestling through this question in our commission meetings. Look, I think there will be tremendous opportunity to leverage AI to optimize outcomes for people living with HIV and those at greatest risk of HIV acquisition. Using chatbots and conversational agents to support people to stay on treatment, using large language models to optimize allocation of scarce resources, using machine learning to predict and anticipate stockouts, right across the continuum of programming that supports the HIV response. There will be important use cases. But I think there is a risk that we think of AI as a shiny new tool or a silver bullet that's going to solve all of our problems that are resulting from a contracting donor response. And the bottom line is that an AI tool won't ever replace community health workers. It won't ever replace ARV drugs for people living with HIV. And if we put all of our eggs in the AI basket, we'll face a rude awakening. The other thing I'll say, this is very nerdy right now, but I've just written about it on my Substack. There was a piece of literature written by an economist in the late 18th century, a guy called Jevons, who wrote the Treatise on Coal. And he made this point that with coal being available at the end of the 19th century, it wouldn't solve all the problems. And in fact, more coal would probably mean more use of coal to drive more steam engines. And I think that's true when we consider the application of AI to HIV programs. It will afford us efficiencies, but those efficiencies will lead us to demand more, raise expectations, close the sort of the latency gaps in our health system, and actually may lead to us doing more rather than less. Might not be a bad thing, but if we think that it's going to make us more efficient and save us money, I think that will be proven not to be the case.
You see, this is what I love about you, Mike. You are able to join dots that could seem completely at odds with each other. I love that that reference to coal. I think this is a subject we're going to come back to very, very regularly, because it is not a magic bullet, as you said, but it could help us and it could help elements of our work. Well, with that, just a huge thank you for spending some time with us here in Kigali. Hope you have a safe trip back to the United States, and we'll see you again very soon.
Thank you, Ben. Pleasure to be with you.
Well, that's it for this episode. Thanks to Mike Reid from UCSF. Thanks also to our local production team here in Kigali, under the expert leadership of Eric Espera, director and producer from A Shot in the Arm Media. And finally, a big thanks to you. You know what to do. Subscribe and like us wherever you download your audio podcasts, and smash that notification button and like and subscribe on our YouTube channel at www.youtube.com/@ShotArmPodcast. So with that, have a great day and a safe day, everyone.